Respected Dean and Chairman of the Platinum Jubilee Committee, my colleagues, friends, and all participants. Osteoarthritis is a universal disease. All of us will someday suffer from this debilitating disease, and almost all of us have a family member who are suffering from osteoarthritis of knee. Before I go to introduce on the topic, I'll introduce our faculty. Our first faculty is Professor Vishwajit Sahu. He is Professor of Orthopaedics in SC Medical College, Qatar, and he is a very strong academician, and he has presented many papers, and he was also IOA Bios fellow. Besides, he was Secretary of Odisha Orthopaedic Association for almost 6 years, and he is also current National Coordinator for CME of Indian Orthopaedic Association. Professor Subhranshu Maheshwari is a rising star in the field of Indian arthroplasty scenario. He is alumni of our college, both UG and PG. He is currently Professor and HOD of St. GS Medical College and King Edward KM Hospital. And he is an internationally acclaimed orthopedic surgeon, arthroplasty surgeon. He was past president of Bombay Orthopedic Society and a current president of Indian Orthopedics Arthroplasty Association. So now coming to introduce the subject, as we discussed and Dean also told, osteoarthritis is a very common disease. It's highly prevalent and disabling disease. It is due to progressive loss of cartilage structure and function. But what is important is there is a lack of disease modifying agents. Most of us have an idea that it is due to aging, but unlike aging, osteoarthritis is a very progressive and a significantly more active process. There are a lot many things about osteoarthritis which does not match with aging, because if it was due to aging, almost 11% people below 40 years suffer from osteoarthritis. And I have seen 24-year-old young men suffering from severe osteoarthritis without any preconditions. And almost 50 to 60% people below 65 suffer from osteoarthritis, and above 65, it is almost universal. And almost 30% people, they suffer symptomatic disease affecting activities of daily life. And coming to the global burden, it is the second only to cardiovascular disease to produce disability. It is the most common cause of pain, loss of functional mobility, loss of time from work due to rheumatology disease. It is the most common cause of joint replacement surgery. In India, currently almost 1.2 lakh TK are done every year. And it is estimated by 2030, there will be almost 100 million people in India waiting to have a joint replacement surgery. So pathogenesis, there is an interplay of different factors like systematic factor and also local biochemical factors. I'll not go into detail, but currently a lot more focus has been given on the molecular aspects of the osteoarthritis leading to collagen synthesis and cartilage cell metabolism. Hopefully something good will come out of it. So I will only diagnose it very easy, but one important thing I will stress here, when most of my friends or other doctors refer, they always do the X-ray in supine position. So most important thing is in osteoarthritis, X-ray should be taken on standing and weight bearing view. This X-ray, if you take in a supine position, it will look like as if it is grade 2 osteoarthritis, where it is now so severe. So early diagnosis is the key for effective management. And there is a classification up to grade 4 by Calligrani. I'll not go into detail. Now, we must learn that there is no therapy to reverse the progression of the disease. ओडिया गोटे कथा अच्छी खसीगला गोड़ तलक तलक. So whenever once the osteoarthritis has started, there is no revert back. It will only progress. So what we can offer is a palliative therapy and improve the quality of activities of daily life that we can offer to the patients. So Professor Vishwajit Sahu will be dealing in detail about the medical management of the treatment. And Professor Subhranshu Mahanti will be dealing on the surgical management. It is said God has given the best knee to human beings, and we don't have any other alternative. And only whatever we have to offer, it is the second best only. And Subhranshu Mahanti, who is authority on this subject of arthroplasty, and will be leading in detail on this aspect of the management. Thank you. So I'll request now Professor Vishwajit Sahu to start with his talk. He should limit his talk to 20 minutes as discussed, and then Professor Mahanti will take up. Thank you.
Good afternoon, everybody. Respected Chairman, Dean and Principal of SC Medical College, Cuttack, Professor Datteswar Hota sir, Moderator, HOD Orthopaedics, Dr. NC Mahapatra sir, esteemed seniors, teachers, faculties, students of all the departments, and respected SCVians all over the world. My topic of presentation today is medical management and physical therapy of primary osteoarthritis of knee. All of us know that what is primary osteoarthritis of the knee. The primary osteoarthritis means it has got no secondary cause. It occurs due to wear and tear process and mostly due to aging process. So it is also known as osteoarthrosis or degenerative joint disease. It is defined as it's a non-inflammatory, it's an idiopathic, degenerative, slow progressive disease of the joints. And it mostly osteoarthritis occurs in the weight-bearing joints. And in Indian population, we people mostly suffer from osteoarthritis knee because of our squatting habits. There occurs degeneration of the articular cartilage and subchondral bone sclerosis. Prevalence of osteoarthritis is quite high in India due to our squatting habit. Females are more commonly affected in osteoarthritis. The common risk factors are age. Age is the strongest risk factor. Although osteoarthritis can start in young adulthood, but if one is more than 45 years old, he is at a higher risk. Female population, yes, before 45, usually osteoarthritis is frequently in men, but after 45, this osteoarthritis is more common in females. If there is a joint injury or overuse caused by physical labor or sports, or if there is a traumatic injury like a ligament or a meniscal tear, then that person is more likely to develop osteoarthritis. Obesity is definitely a strongest risk factor. Being overweight during the midlife or the later years is among one of the strongest risk factors for developing osteoarthritis of the knee. Dietary deficiency like vitamin D has got some relation to the development of osteoarthritis. What are the common complaints of osteoarthritis? The common complaints are pain, pain, and pain. Most common is the pain in the knee joint and stiffness. So if the patient typical, they will complain of some other things like they get stuck at times, they can't go up the steps, can't walk for a small distance. Some will say that the joint is giving away or there is a fear of filling. There will be some deformity, but most common deformity is bow leg or genuvarum. Sometimes there may be knock knee, and some people say that they can't sleep at night. I'm not going into pathophysiology. Little bit of pathophysiology primarily affects the articular cartilage, and hydropic degeneration occurs that leads to fibrillation of the cartilage and all. There are 4 stages of the knee osteoarthritis: doubtful, mild, moderate, and severe. The severe is the grade for osteoarthritis where joint space is grossly reduced and is more than 60% of the cartilage is already lost and there are large osteophytes at the end of the articular margins. Yes, coming to the treatment, there is no proper or true cure of the disease, but the progress of osteoarthritis of knee can be controlled or delayed. Why you need to treat the osteoarthritis? Because the patient is suffering from the symptom of pain. That is very important. Patient always will say that my pain should go away by any means, doctor. And it is associated with quite a lot of morbidity. And number 3 is quality of life. Nowadays, the quantity of life is not that important. The quality of life is more important. Always the patient will request for relief of the pain. So the treatment always depends on the symptoms. We have to explain the pros and cons of treatment options so that the patient will make a correct option. It is not an easy reality to face, but just as your chronic pain did not develop overnight, neither will the solution to finding the relief develop in a day or 2. So what are the keys to management? The keys to management, if the patient is obese, we have to start conservative management. If it is not getting relief by conservative management, then we can think of surgical management. You have to reduce the weight if patient is obese. You have to give psychological therapy, activity modification and strengthening exercises, pharmaceutical or drug therapy. And if nothing is, the pain is not getting relieved by all these modalities, one can think of different surgical options. So coming to drug therapy in a case of or medical management of osteoarthritis, commonly we use analgesics. The common analgesics are used tramadol, paracetamol combination and paracetamol. Plain paracetamol we give as a need basis, maximum 4 grams can be given in a day. It is one of the safest painkiller what we prescribe in a case of osteoarthritis knee. Local anti-inflammatory gels can be used for 2 to 3 times. You can apply it locally and gently. NSAIDs are reserved for acute exacerbation of pain for a week to 10 days. Duloxetine, which is a centrally acting agent, can be used. And if the patient is obese, then you have to advise for weight reduction. Nutraceutical therapy or disease modifying osteoarthritis drugs are there. There are so many drugs are there. Now, which was first used, which was glucosamine, and it was believed to have some chondroprotective and regenerative properties. The dose was 1500 milligram in divided doses. And usually all these nutraceuticals are given for a longer period, say up to 3 to 4 months. Next in the line is the chondroitin. It's a dietary supplement believed to have some chondroprotective and reparative effect. The dose is usually 800 milligram, usually given in combination with the glucosamine. The third one is the collagen derivatives like collagen hydroxylate and denatured collagen. It has got some beneficial effect in osteoarthritis knee, but no definitive conclusion has been reached till date. Then diacerin. Diacerin is typically known as cis-DOA, that is symptomatic, slow-acting drug in osteoarthritis. The dose is usually 50 milligram twice daily. It has got anti-inflammatory, anti-catabolic, and pro-anabolic properties on cartilage and synovial membrane. And my take in this drug therapy is, till date, no drug has been developed that has shown definitive evidence of slowing or reversing the pathological changes in osteoarthritis of the knee. Other things have been tried like intra-articular steroid injection. You can inject steroid into the knee joint, but it has got its own side effects. It usually reserved for flares or relief of pain from acute exacerbation of the arthritic pain. It gives pain relief only for a short term, but it is associated with some complications like joint infection, accelerated degradation of the articular cartilage, and subchondral insufficiency fractures. Orthobiologics are of recent use. So what is orthobiologics? As defined by the American Academy of Orthopaedic Surgeons, the orthobiologics are biological substances that are found naturally in the body that help injuries heal more quickly. These orthobiologics, they are the hyaluronic acid, that is we call commonly viscosupplementation, platelet-rich plasma or PRP, bone marrow aspirate concentrate, and adipose tissue autograft. All these things can be injected intra-articularly into knee joint for relief of pain in grade 2, grade 3 osteoarthritis of the knee. So knee injection, what commonly we give hyaluronic acid. The process, it is called a viscosupplementation injection that lubricates and cushions our knee joint. It can provide pain relief up to 9 months. So the effects of the hyaluronic acid injection is it has got lubricating ability, it stimulates natural joint lining, natural joint fluid, reduces pain by putting damaged surfaces, and it has got some anti-inflammatory action. It can be directly injected intra-articular into the joint. It is usually outpatient procedure, takes a very few and patient can start normal activities very soon. It is commonly used in grade 2, grade 3 knee osteoarthritis, but American College of Rheumatology makes no official statement for its use till now. Then comes PRP, that is platelet-rich plasma. It is quite cheap, prepared from patient's blood. It is PRP is a rich source of growth factors like platelet-derived growth factor and vascular endothelial growth factors. These growth factors, they promote chondrocyte proliferation and they stimulate mesenchymal cell to increase production of type 2 collagen. And it inhibits interleukin-1 that has got anti-inflammatory and analgesic effect. And literature say there is a significant pain relief for almost 12 months. So to get a PRP, you have to centrifuge it for 10 to 12 minutes at the 3,500 to 4,000 RPM. After centrifusion, you have to collect the PRP after removal of the platelet poor plasma. So you have to get platelet rich plasma after centrifusion. So this platelet rich plasma you can inject either by free hand or by ultrasound guide or assistance. You have to inject after aspirating the synovial fluid from the knee joint. So bone marrow aspiration concentrate and mesenchymal stem cells, they are similar to platelet rich plasma. The further long-term studies required to validate their routine use. There are some experimental drugs like intraarticular injection of growth factors such as transforming growth factor beta 1, bone morphogenic protein 7, insulin-like growth factor, fibroblast growth factor, endodermal growth factor, and interleukin-1 inhibitor. All these things are on experimental basis. It has been seen that a single injection of transforming growth factor beta 1 stimulates a persistent increase in cartilage proteoglycan synthesis and content. Gene therapy is of recent use. Gene transfer techniques which will suppress inflammatory factors or overexpress growth factors. They can be delivered by viral or non-viral vectors. Gene expressing transferring growth factor beta 1 has been targeted and has shown to be effective in early clinical studies. The future, we are in an era of tissue engineering. Hopefully, a day will come when we will be able to replace a part or whole of the damaged articular cartilage by new cartilage cells that is developed by induced mesenchymal stem cells. There are some knee braces these are called offloading knee braces, can be used in a case of osteoarthritis because osteoarthritis usually affects the medial compartment or inner side of the knee joint. So you can offload by transferring the weight transmission from the medial side to the lateral side by giving such type of offloading knee braces. So they will movement side to side mobility and they will bypass the transmission weight through the damaged cartilage. And so lateral heel weights can be used, but it is not that much recommended. Any kind of physical activity like walking, jogging, cycling, yoga, gym, swimming, and sports are advised. One has to use good footwear with arch support so that they can delay the process. You have to avoid roaming around, go barefoot in the house. Every time you want to pick something from the ground, try and squat in a proper manner. Whenever you have a tiring day in an office or a house, stretch your body before going to bed. When use a stool or a small table to alternate weight shift if you have to stand for long hours. Avoid squatting, avoid climbing stairs. Use a commode as far as possible. Physical therapy like ultrasound therapy, pulse TMT, TENS, short wave diathermy, interference therapy, Swedish massage, all these things are there which are beneficial, but they have got it's inconclusive. Exercise and physiotherapy, they are cornerstones of osteoarthritis because in osteoarthritis, muscles around the knee joint, they become weak. So getting the optimum strength of the muscles around the joint has shown to decrease the pain as well as improve the overall quality of the life of the patient. So exercise are very important. The golden rules of the exercise are you have to do the exercise, you have to do it regularly, you have to do it correctly, and don't overdo it. The last one is very important. Don't overdo exercise. Okay, you can go for free cycling for 5 to 10 minutes at zero resistance. Static cycling is always better. It's a very good form of exercise because static cycling helps in cartilage nutrition by continuous passive motion type of action. It can be repeated twice a day. Different type of exercise like standing hamstring stretch, quadricep stretch, side lying leg lift, prone hip extension, calm exercise step up, wall squat with a ball and straight leg exercise. All these things have been advised. Next I will show you a short video So these are the 5 exercises one has to do. So static quadriceps exercise, dynamic quadriceps exercise, hip abductor strengthening exercises, calf and hamstring stretching exercise, and vastus medialis obliquus strengthening exercise. These are the 5 common exercises what we advise the patient in our orthopedic OPD to each and every osteoarthritis of the knee patients. Yoga for osteoarthritis has got definitely some role. Different poses are advised like pigeon pose, knee to chest pose, and breeze pose. Then is Tai Chi. Tai Chi is strongly recommended by Chinese people. Tai Chi means it's a supreme ultimate. This is a traditional Chinese mind-body training exercise, and it increases flexibility as well as the balance. What will happen if we don't treat arthritis? This osteoarthritis has to be treated. If you are not going to treat, the pain is likely to increase, and it will be sometimes debilitating also. The stiffness of the joint will increase, and there will be frequent falls from the instability of the joint. So other diseases may likely make their appearance, like some heart diseases, depression, and obesity. So my take-home message for all the audience is that osteoarthritis of knees should not be regarded as a disease. Rather, the ONE is a pathophysiological change. The management is always multimodal. The treatment in early stages always gives the best result. NSAIDs provide only symptomatic relief. Paracetamol is a safe analgesic, can be given up to 4 grams per day. One can advise 1 gram 6 hourly after food. Nutraceuticals or disease modifying drugs have questionable benefit, and they have, to get some benefit, they have to be continued for a prolonged period, say up to 3 to 4 months. Lifestyle modification and physical therapy are 2 cornerstones of effective management of osteoarthritis of the knee. Orthobiologics and gene therapy are evolving and may hold the key to cure the osteoarthritis of knee in the future. Thank you for your patient hearing.
Thank you, Professor Sahu, for such a nice presentation on the medical management. We'll keep the questions to the end. I hope, because it's such a common disease, we'll have a lot of questions to ask to our presenters. Now I invite Professor Subhranshu Mahanti to give his lecture on the surgical management of osteoarthritis.
Am I visible and audible?
Yes, audible and visible also.
Thank you. Thank you, respected teachers, dear colleagues of the orthopedics department, and dear friends. It's really a pleasure and honor to be here and deliver the pre-platinum Jubilee CME program. And I'm grateful to Professor Datteswar Hosta, the Dean and Principal of SC Medical College, Professor N.C. Mahapatra, Professor and Head of Orthopedics Department, and Professor Biswajit Sahu for giving me an opportunity to share my views about the surgical management of osteoarthritis of knee. Friends, it's always a nostalgia or feeling of nostalgic whenever I come as an examiner or whenever I participate in any CME involving the SC Medical College. These are the couple of pictures which I gathered that I always used to participate in the one-act plays. This is one of the plays which are Kacha Ghara, which was played during that time during my undergraduate career. And that is where in the SCB auditorium itself. And this is our PHM tour in final year. And next to me is Dr. Biswajit Sahu. You can see my classmate and dear friend. There is a Dr. Siddharth Satpathy who is heading the hospital administration department at All India Institute, Delhi. This is Dr. Satyajit Satpathy, who is a leading psychiatrist at Dallas, Texas in the United States. And Dr. Prabir Nandi, probably he is attending this CMA as well. He is practicing at Jamshedpur. And it culminated in me being the best graduate in 1989 and receiving the medal during the Utkal University convocation. So 10 years I spent in the campus, both undergraduate and postgraduate period. Now, a couple of years back, almost about say 10 years back probably, I was going through a journal called Business World. And it was focusing on what is the business of old age. And you will be surprised to know that time, the total annual expenditure for the management of arthritis in our country was 766 crores, and which surpassed the expenses due to any other chronic illnesses like diabetes, hypertension, osteoporosis, whatever. And if you see in that journal, it was mentioned that at that time, about 12% people more than 60 years and almost 1/3 of people more than 70 years were arthritic. And it was predicted that probably by the year 2025, 33% of our population might require a joint replacement surgery. So after listening to this, figures, probably the number of people who are attending here, nearly 200, almost I think 50% or maybe more than that people must be having some kind of knee pain because of aging process. And the commonest arthritis, what you see in our OPD is osteoarthritis of knee, followed by rheumatoid arthritis. And there are hundreds of varieties of arthritis, which is seen by the rheumatologist. But as an orthopedic surgeon, we see osteoarthritis as the commonest variety. Dr. Sahu focused on medical management. I'm going to focus on the surgical management. And I'm going through on a case-by-case basis because this is a multi-speciality CME. So it will be easier to understand. The first and most important thing in the surgical aspect is a arthroscopic debridement. Now, suppose this is a 54 years old female, so has a pain in the right knee, and she has reasonable joint space which is present. But when the MRI was done, it shows there is a cartilage tear. And if it can be demonstrated that pain in the knee is due to the meniscus tear, or this is known degenerative meniscus tear, then one can go ahead and do a partial meniscectomy. Otherwise, partial meniscectomy do not have any role in a degenerative joint disease. The second case, when a 45 years old male, repeated locking episodes in the knee, and if when you do a CT scan or MRI, you see multiple loose bodies, and these loose bodies are coming in the way of the movements and causing locking episodes. And one can do a arthroscopy to take out these loose bodies. The third case scenario is a 49 years old male, swelling and restriction of the range of movements. And it's an inflammatory variety of osteoarthritis where the MRI shows there is a synovial hypertrophy with effusion and all these things. So arthroscopically, one can do a synovectomy. So at present in 2021, these are the three indications of arthroscopy in a degenerative knee or osteoarthritis knee. Otherwise, there is no role of arthroscopy in osteoarthritis. Let's see what are the American Academy says. The recommendation is that there is a strong recommendation that we cannot recommend performing arthroscopy with lavas and or debridement in patients with primary diagnosis of symptomatic osteoarthritis of knee. And the second recommendation is that there is inconclusive evidence, or we are unable to recommend for or against arthroscopy partial meniscectomy in patients with osteoarthritis of the knee in a torn meniscus. So the evidence is poor, but still in some patient it helps, but you should do a properly indicated patient in these three conditions where pain will improve after doing arthroscopy. The second thing is doing a osteotomy. In osteotomy, we take out a wedge of the bone and restore the alignment of the limb. It is indicated when the pain significantly affects or significantly it is disabled the person, affecting the activities of daily living. There is unicompartmental disease. That means either the medial or lateral compartment is involved, varus or valgus deformity, and there is not much of a varus deformity should be less than 15 degrees, and patient should have a good range of movements. Suppose this is a patient, this is a 57 years old male. He has got pain both knees, left more than the right, and unable to walk more than 15 to 20 minutes, and unable to stand for a long time. And X-ray shows there is some joint space is still preserved there, and there's a varus deformity. And sometimes we do this, patient goes to gait lab to see the gait pattern of this patient. There's a bilateral varus thrust of this patient, as you can see here, and left more than the right. So in this kind of patient, the osteotomy is indicated, and a distal femoral osteotomy, take out a wedge of the bone and do a valgus osteotomy of the femur. And now this is an open wedge osteotomy, putting some kind of fixator, and so you restore the alignment of the joint to horizontal from the varus. That is after the left knee surgery, that there is no varus thrust and restoration of the joint line in this patient and become pain-free. There are two kinds of osteotomies where you can take out a wedge like this and realign the joint to make it neutral or valgus. This is a closed wedge osteotomy we tell, or you can do an open wedge osteotomy. So you make a osteotomy, cut the bone and open it up and put some kind of bone grafts or some kind of plate like this special medicine on the open wedge osteotomy. Let's see what the literature says. The systematic review in 2021 shows young patients with knee osteoarthritis, high tibial osteotomy has got a better long-term survival rate. It reduces the economic burden and promotes the reasonable allocation of medical resources. And open wedge osteotomy is advantageous compared to closed wedge, that it is long-term survival rate and lower fracture rate, but the level of evidence is still lower. So open wedge osteotomy partially indicated in young patients. The third thing comes into picture is a unicondylar knee replacement, where one compartment is affected and you do only replacement of that compartment. But there is a highly selective indication. So one must know that how to select that ideal patient for unicondylar knee arthroplasty amongst the cohort of all the arthritic patients. So age should be beyond 60 years, low activity levels, and flexion should be beyond 90 degrees. Patient should have a good range of movements and with a minimal deformity like varus and valgus deformity should be less than 15 degrees. So this is a unicondylar knee replacement where you replace only one compartment of the knee. But in a meta-analysis in 2019, it shows there's a long learning curve. So complication rates are higher than doing a total knee replacement, and total knee replacement is more reproducible. And here the revision rates are higher in unicondylar knee replacement. So it is recommended that if a surgeon is not doing at least 20 unicondylar knees in a year, should not perform a unicondylar knee replacement, and there the complication rates are high than doing a occasional unicondylar knee replacement. This is how it looks from the side, and this is how it looks in the X-ray, where the varus knee is converted to a neutral, or still the varus may persist. So it is an under-corrected knee. You cannot correct this knee to a valgus alignment because the lateral compartment is normal. What Dr. Ranawat tells that unicondylar knee is the work of devil, but when they work great. So in a properly trained hands, it will at least buy 10 to 20 years of your time. The last option remains a total knee replacement. Now the indication that if the patient has got an incapacitating pain in more than 60 years of age, or even if patient is younger, if there's severe disabling disorders even at an earlier age. But the most important indication is pain, pain, and pain. That means pain at rest, pain at night, pain which hampers activities of daily living in spite of usual intake of the analgesics. But knee replacement also, restores the mobility of the joint, good functional mobility. If the joint is unstable, we achieve stability to the joint, correct the deformity. So these are the 4 indications of total knee replacement, and correct the limb length if possible. But the most important indication is that pain relief. Unless the patient has pain, one should not undertake a knee replacement surgery just for getting the mobility, or just to get a stability of the joint, or just to correct the deformity. Suppose this is a case, 56-year-old female, both knee pain, bilateral bone knee deformity. Clinically, if you see, she has got a very good range of movements. And if you see on the right side also, very good range of movements. But if you look at this lady in 56 years, you definitely, think of doing a total knee replacement. But when the x-rays are done, if you see the x-rays, the joint space are pretty maintained. There is no osteophytes, and there are no, loose bodies there. So all these things point that this patient doesn't require a knee replacement surgery. So please remember, one is a patient, one is the x-ray. When patient has a lot of pain, x-ray looks bad, stage 4, Kelligan, Lawrence classification, what Professor Mahapatra was showing, then the indication is a surgery. And sometimes what happens, patient have a lot of pain, but x-ray looks normal, like in this case, or the opposite. Patient doesn't have much pain, but the x-ray looks very bad. Then one should wait and treat them with some conservative treatment rather than taking this patient for surgery. Now, this is another patient on the other hand, 52 years male, bilateral osteoarthritic knees, stage 4, and it's significantly affecting the activities daily living, that he has to hold a stick to walk with a lot of difficulty. And when you see an x-ray like this, there's a bad arthritis with, there is also necrosis of the medial condyle of the bone. So this kind of patient, they benefit from a knee replacement surgery. And this is a 13-year follow-up of doing both the knees in this particular patient. And because of a lot of bony destruction, we had to put grafts and then put some screws to build up that bone and restore the alignment. And that is the function at 13 years. Now, this is 72 years old female again, severe flexion contracture of both the knees with bad arthritic knee, that she has to spend a lot of energy in order to be ambulatory. And that is 4.5 years follow-up of this patient. The alignment is restored, the deformity is corrected, pain is relieved, and significant improvement in the function and quality of life. But one must remember the absolute contraindication, that if there's any recent sepsis in the joint, one should not do this surgery. Inadequate soft tissue coverage, the muscles has to move the joint. If the muscles are not there, then who will move the joint? And last and important point is poor limb perfusion, if there is severe peripheral vascular disease. For example, this is a patient, 74 years old female, 7 months post-op. The X-ray looks so pristine. The alignment is restored and nicely done total knee replacement. Unfortunately, landed up in infection. There is a discharging sinus, and gradually toes became gangrenous. The dorsalis petis, posterior tibial, both were not palpable. When he did an angiogram, as you can see, a distal to the popliteal artery, there is no blood flow at all. So before doing a total knee replacement, one must palpate the dorsalis pedis and posterior tibial artery. If one of the pulses should at least be palpable. If both the pulses are not palpable, then send the patient for CT angio and see that whether the vascularity is there. Otherwise, you will land up in problems during post-operative period. Ultimately, this patient landed up in a AVOM knee amputation. You require a good laminar airflow theater, because infection is the biggest enemy of this total knee replacement theater, the total knee replacement operation. And if possible, you should have this kind of space suit, or what we tell body exhaust suits, so that even the surgeon's breath also doesn't fall on the patient's wound. And the type of prosthesis, these are the fixed bearing knee which are available traditionally, but there are a lot of movements between this polyethylene and this base plate that led to backside wear or wear of the components. So now we are using more and more this rotating platform knees or mobile bearing knee. So there is no back wear. That means there is a movement between this metallic part and this plastic part, and there is a movement between this plastic and this tibial part. So there is a movement in both the planes that reduces the wear, and there is no back wear or loosening of the prosthesis like this. This is a monoblock prosthesis, are all polyethylene tibia. This is a plastic-like material, and it has shown very good long-term outcome. We had published in 2004, and also it was I received the second James Rand Award from the American Academy for the best paper in the clinical knee research. Now, high flexion knee. People ask about whether I can do the ground level activities, sitting cross-legged, squatting like that. High flexion knees came into the armamentarium. But remember, for Western people to do a pain-free post-operative range of movements about 110 degree, it is required for their activities of daily living. But for the Asian population, we need squatting, kneeling, sitting, all these things. But the forces required is 5 to 7 times the body weight, and hence it puts more stress on the knees, and that's why because that will lead to wear and tear of the components, and the process will fail earlier. So if you do a proper surgical technique, take proper bone cuts, you balance your gaps well, fat preservation, and take a thicker patellar bone, then even with the conventional knees, you can achieve a full flexion on the table like this. So there the surgical technique remains, hallmark of this operation. Full flexion even in the conventional knees can be achieved. Now, this is a bilateral total knee replacement done in Odisha in about 14 years back with a elephant limb. This is a lady which is about, probably now 60 to 63 years. She just came last month, for a follow-up. The knee looks so pristine, and there is no, wear and tear, and alignment, and the function of the patient is still restored. Now, this is a grossly unstable knee, both knees. This is a young patient, 42 years, secondary osteoarthritis. And he's able to hold with 2 crutches, and the knee is totally destroyed like this. That is why the role of early surgery remains. If you are painful, the joint doesn't become such instability, such unstable in mediolaterally as well as anteroposterior direction. If you do a CT scan, if you see the lower end of the femur, it just looks like a claw. There's a lot of bone destruction because patient is walking over that still with this arthritic knee. And that is a 7-year follow-up of this patient after replacing both the knees, and of course we replaced one of the hips also, and it's a full-length X-ray of this patient. There we had to use a specialized components because these components has to maintain the balance in this grossly unstable knee. So bilateral total knee replacement, the short-term and long-term outcomes are equal if you do one knee at a time or do both the knee at a time. But remember, the patient's cardiac status has to be checked, and if cardiac status is good, but the incidence of complications are little higher with respect to infection, embolism, and pain, but they're less cost and single anesthesia, single hospitalization, especially you do it in severely deformed knees where patient is motivated to do a adequate physiotherapy post-operatively. Now, infection is the biggest enemy, and when there's an infection in the knee, we have to do a 2-stage reconstruction, take out all these implant, put an antibiotic impregnated cement spacer inside, and after treating with antibiotic, when ESR CRP goes down and when the knee looks dry, then we go ahead with putting the another knee inside, and that's a revision surgery. That's a 7-year follow-up of this lady. Rehabilitation progress after total knee replacement, the greatest improvement is found in the first 3 months. So first 3 months, one should do a good exercise program in order to get maximum benefit out of the knee replacement surgery. Then gradually it becomes slower until about 5 months to 6 months, and there is hardly any improvement occurs after about 5 to 6 months of the surgery. These are the recommendation activity which can be done after knee replacement. Suitable, you can do cycling, swimming, low resistance rowing, walking, stair climbing, and you can do also dancing like ballroom dancing or square dancing. But please avoid all the high impact aerobics or high impact sports. Jogging, parachuting, and even powerlifting also should be avoided after a knee replacement surgery. Now, a word about the recent advancements in surgical treatment of osteoarthritis of the knee. These are the autologous chondrocyte implantation. But this is possible when there's only a single defect or only small defects are there. Then you take the cartilage from the non-articular side and just impact it at the defect. This is post-operatively. And now there's the autologous chondrocyte implantation by doing chondrocyte cultures. So this is the damaged cartilage there. So one takes the biopsy from the healthy cartilage and sends it outside. This is in vitro culture of the chondrocytes. Then these chondrocytes are injected into the defect under the cover of a patch of periosteum which is taken from the tibia and stitched it, and this is injected there. But 2017 literature, out of 4 randomized controlled trial, still the question is about its cost effectiveness because it is very, very expensive. And of course, the long-term results are still questionable. Now, regarding the joint replacement, we have now patellofemoral joint. Suppose the patient has got a significant patellofemoral arthritis where the main joints are maintained, then patellofemoral joint can be replaced, or one can do a duo, both compartment replacement, like patellofemoral as well as the medial condyle or medial compartment replacement. But the long-term results are still questionable. These are at experimental stage, but it is available now for the commercial use for the doctors. So patellofemoral joint and bicompartmental knees. Now, computer-assisted surgery and robotic surgery. This has come, computer had come, and now gradually computer is going out of the market and robots are coming into the market. But one must remember the basic principle. Computer doesn't make an average surgeon a better surgeon. So one must have at least 50 to 100 conventional knees one should do before switching onto a computer. On the other hand, the results are not significantly better between an experienced surgeon and computer-assisted surgeon. So on either way, the results are not better when you do on the computer and a robot. But there are certain specific conditions like in a badly deformed or malunited fractures. Then in those cases, computer and robotics may be helpful. So it works by GIGO principle, what we tell garbage in and garbage out. So you have to feed the computer properly in order to get proper outcome of your surgery. Now the results of cemented total knee replacement is well established over the period of last 20-30 years. You can see 91 to 99% survivorship at the end of 10 years until about 96% at the end of 15 years. Now in the horizon, there are cementless total knee replacement that where we can see that we can fix the components without using bone cement, but still it is just gradually getting popularity. So one must remember there should have, for any type of surgery, there should be a proper selected indication of the surgery. Then you select a proper implant for that particular patient, and of course the craft or technique of the surgeon. So here there is a conglomeration of technique and technology. So proper implant selection and proper craft or technology can give rise to a very good outcome of the surgery. What Merrill Ritter has told that, most painful replacements are because of infection inoculated during the surgery. But if you are looking at 10 years, 15 years, 20 years down the line, then careful attention to the technique and quality of implant can make the difference between successful, symptomatic, and failed total joint replacements. Dear friends, quality is never an accident. It is always the result of high intention, sincere efforts, intelligent direction, and skillful execution. And that is what we have inculcated as SCVNs. I thank you for a patient hearing.
Thank you, Professor Mahandi, for such a nice and elaborate lecture. I'm sure most of our friends, almost all orthopedic surgeons attending and all faculty will be benefited, and they will have a gross idea about the recent development in field of surgery in osteoarthritis. Now I request all the members attending and the webinar, please ask questions.
No. Just hold on.
Sir.
In fact, our request are that we will have a very timely discussion. I had requested that they should put in the chat. So if they have
Sir, I have two questions in chat. I'll ask it, sir.
So finish up the chat questions. If time permits, you can go for further questions because we have to complete by 5:10.
Sir, there is one question for Subhranshu. How has the COVID-19 affected the knee replacement surgeries?
Actually, COVID-19, we have stopped all the knee replacement surgery is considered an elective surgery. And during the COVID-19 period, we have stopped all the elective surgeries like knee replacement and hip replacement surgeries. So gradually we are starting up now as we are opening up, but definitely if the patient is a COVID positive, one should not, go ahead doing RT-PCR and go ahead with the surgery like that. So right now, whenever the patients come, we ask whether there is a history of COVID infection. If there is a COVID infection within 3 months, then we do not take this patient for surgery because it's a major operation And post-operatively, it's likely that patient may get a COVID infection, or patient may have because of immunosuppression, get an infection of the knee replacement surgery. So if it is after 3 months, then we can take these patients for surgery. Whereas hip replacements, post-COVID, we are getting more of avascular necrosis of the hip. Right now, we have started getting these patients. Every OPD, we are seeing 1 or 2 patients who have been suffered from COVID or has been treated with steroids for COVID infection. So that leads to avascular necrosis, because COVID itself causes, it has got a thrombotic phenomenon that can cause avascular necrosis. So definitely we are seeing more number of avascular necrosis of the hip, which may land up in the joint replacement, later on.
Okay, thank you. There is another question for Vishwajit. Which is better, physiotherapy at home or under supervision? How will you advise physio at the home during COVID times?
Physiotherapy under supervision is always better. Under supervision, under the guidance of a physiotherapist, is always better than doing yourself at home. So during COVID times, things are different. But in normal times, one should ideally start doing physiotherapy under supervision. Once you know the techniques and proper how to do it properly, then you can do it at your home. So during COVID times, what we can do, we can teach the patients, and after that we can ask the patient to follow some charts of doing exercise. We can send them some videos of doing exercise the way we demonstrated 5 exercises: static quadriceps, static dynamic quadriceps exercise, hip abduction exercise, stretching of the calf and stretching of the hamstrings, and vastus medialis obliquus, because that muscle gets wasted fast. So you have to strengthen the vastus medialis muscle. So all this exercise we have to show them by chart or by video. We can send them so that the patient can do at their home properly.
There is one question by Dr. Sasmita Swain. Maybe Subhanshu will take up. Cooking in standing or sitting position, which one is better to prevent osteoarthritis, Indian or Western fan in toilets?
Western pan.
Very, very good question. Actually, standing or sitting doesn't cause osteoarthritis. Well, if you see the pathogenesis of osteoarthritis, it is a microfracture of the cartilage or microfracture of the subchondral bone, which initiates a whole pathological process that leads to release of those matrix metalloproteinase. Vidut sir will explain better all these things. He has been teaching us from our undergraduate days. So the standing or sitting doesn't lead to osteoarthritis, but that doesn't make a difference. But when you are standing, at least just keep on doing a quadriceps exercise. Just make the knee tight or loose, at Dr. Sahu showed in the picture, quadriceps exercise, static quadriceps exercise. Do it also every 5 minutes or 10 minutes, something like that. Along with your other work, you can do that. While sitting also, you can stretch your work and you can leg and do it. While sleeping also, you can do it. So that doesn't make a difference. But gradually one should avoid the ground level activities like sitting cross-legged, squatting, sitting on the floor. One, if it's beyond 40 years, gradually we need to avoid this thing, because that is one of the reasons why Indians develop more of osteoarthritis of the knee.
Okay, there is one question by Dr.
Yeah, that's correct. Yeah, please.
So, maybe Vishwajit will take up a role of celery seed extract in the management of osteoarthritis.
Yes, these celery seed extracts have been, people are telling, is literature telling that they have got some anti-inflammatory properties. So yes, they have got some, patient can get relief of pain to some extent.
Well, there is one question by from Manoranjan Behra, or maybe Professor Subhanshu Mahanti can answer that. Why doctors C. Ranabhat did take care of late Prime Minister Vajpayee despite surgeons like Professor Dave was heading AIMS Orthopaedics department? Was it technical or something else?
I think this is not a question at all. This is an observation. You should not go into these questions.
Well, sure, sir. I agree with you. Maybe one more question is there by Amit Das. Should knee osteoarthritis be considered public health problem and primary prevention should be taken? Maybe Professor Vishwajit will take up that.
I think you can consider osteoarthritis as a public health problem. because it is quite in patient used to sometimes have used to develop incapacitating pain, and almost 30 to 40% people are developing osteoarthritis. Females are more commonly affected. It's very prevalent all over India due to our squatting habits. I think it should be considered as a public health problem in India.
Sir, I think that's all. There is no more question. Maybe
I think if somebody has any very specific observation, I think somebody has raised hand. Can you please tell your name and you can come in.
My question is, so I'm Dr. Suman Panda from Tata Min Hospital, Jamshedpur.
Okay, okay.
My first question, I'm also in SCBN. My
That's very
first
nice.
question,
That is very nice to hear, but you should have written your name so that you could have recognized also.
Sir,
Anyway.
Namaskar, sir.
Namaskar.
Dr. Sir, Namaskar.
Namaskar.
Dr. Subhranshu, Dr. Vishwajit Sahu are my best mates. My first question to Dr. Vishwajit Sahu. Most people with severe osteoarthritis do not want to go for joint replacement. So what do you recommend for the most person who do not want to go for surgery? My next question is to Dr. Subhranshu. After knee replacement, can one go for mountain climbing? Many people like to go for Tirth Yatra, like Kedarnath, Badrinath, or go for Kailash Mansarovar. Or can one go for mountain climbing?
Yes, Dr. Suman.
My first, yeah.
Yes. Treatment of osteoarthritis is medical management and physical therapy in early stages. Like say grade 1 or grade 1, 2, 3, up to 3, one can go for conservative management. Like what I have said, like medical management with drug therapy, then disease modifying osteoarthritis drugs, nutraceuticals like diacerin, glucosamine, chondroitin. Then one can try intra-articular hyaluronic injection. Sometimes in acute flares, we can use steroid injections. You can go for PRP, platelet-rich plasma injections. So all these things can be tried in grade 2, grade 3 osteoarthritis, along with physiotherapy. Physiotherapy is very important. Orthobiologics and physiotherapy, they are very important in grade 2 and grade 3. But once it's an advancing stage or grade 4, I think medical management will not help. Because nowadays, the quality of life is more important. Quantity of life is not important. Nowadays, quality of life is important and patient wants to get rid of pain. So I think one should think of surgical options in advanced stage of arthritis.
Thank you, Suman, for asking these questions. Now, just one point I beg to differ from Dr. Sahu regarding steroid injection. We have stopped injecting, steroids to osteoarthritis knee for the last almost 12 to 15 years because, steroid injection causes more damage to the joint rather than causing any benefit. Steroids, though it is injected in other inflammatory arthritis, but in osteoarthritis, steroids we have stopped. We are giving, all this sin-based injection, other things, but not steroids. Next, regarding your question that can the patient after a knee replacement surgery climb, do a mountaineering? Yes, mountaineering can be done, but any high impact activities like jumping, those are the things one need to avoid. Jumping, running, like that. Walking, mountaineering, that doesn't, though it will have a more stress on the joint, but still this is not, avoided after doing a knee replacement surgery. And why many patients do not want to do knee replacement surgery? Because they have seen their, neighbor or somebody, some friend has got some complication. That's why they don't want to undergo knee replacement surgery unless till they become wheelchair bound and then they will come to the OPD to do a knee replacement surgery. I tell them that it's not that every patient is different. We cannot tell that every patient is same, that somebody has got an infection, that's why, I'll have infection, or somebody doesn't have infection, then I will not have infection. Every surgery has got its own complications and it has got its own share of complication, about 4 to 5%. But if you see the results, if it is 95, 96% survivors, if at the end of 15 years, it is classified as a very successful surgery and one need to go ahead with it. Whenever it is required, one has reached stage 4 and sufficiently painful.
Thank you. I think this is very interesting, very common. So it can go on for long. But I have one question.
Thank you.
At least I'm privileged to ask one question, which has two components. First of all, up to what age, even if it is he is physically fit, you would like to go for a knee replacement, if it is if there is an indication. That is first. The second component of the question is that in those failed cases, what is the salvage?
One question. Yeah. The first part is that up to what age you should do a knee replacement surgery. The thing is that, there is no age bar for a knee replacement surgery. Though we tell that one should delay it as far as possible, but if the patient is sufficiently painful and symptomatic, and X-ray shows there is a sufficient, destruction of the joint and it's a stage 4, bone to bone, touching all bone to bone, the entire cartilage is gone. There is no point in waiting for a, for a knee replacement surgery, because this surgery is so much reproducible and so much, successful that one should go ahead with the surgery. Now, what is the longevity that if it fails after suppose 15 years, 20 years, it failed, that is known as aseptic loosening or wear of the joint. Then we have to take out all these joints and clean it and put a revision prosthesis, revision surgery, what we tell. Of course, the revision surgery longevity is not as good as the primary surgery, what we tell 15, 20 years. It may be little less. But in expert hands, and when you restore the ligament balance, restore the alignment, and restore the, all these things are restored, bone, whatever bone loss is there, it is reconstructed properly, then it has got a sufficiently good outcome. So there is a revision surgery. Like you are buying a car, and after 5 years, 10 years, we're discarding buying another car. It's an artificial thing. When it wears and tears off, so we take it out and put, another prosthesis in.
Thank you. I think since so many people have mentioned about the rheumatologist, role of the rheumatologist, if Professor Bijit Das is there, he can give a small observation, quick observation.
Hi, Subhranshu.
Hello, sir.
Nice seeing you after a long time.
Yeah.
Osteoarthritis, of course, is the domain of orthopedician, and we see a lot of secondary osteoarthritis. Mostly primary come and we actually tell them to go to the orthopedicians. But you know how osteoarthritis patients are. They are not very happy, so they come back to us again. Necessary to do something. And I think all the treatment that we give is placebo, basically. So what Vishwajit said is absolutely correct. Physiotherapy, paracetamol is correct. But two types of patients we see which needs a little bit of intervention is called CPPD. We see a lot of CPPD, especially elderly osteoarthritis. We see the chondrocalcinosis, and they respond dramatically to Jicolchin. I must have treated several dozens of patients with Jicolchin and dramatic response. And CPPD can aggravate and cause further damage to it. And the other one is overlap, like somebody has rheumatoid, angstpond, and then osteoarthritis. There they respond to anti-inflammatory and DMARDs. The question that I have is, our ankylosing spondylitis patients are very young, something like 20s. They're bedridden because they come to us very late with bilateral hip and knee. And I've been asking Nirmal whether you can take them up for what Dean sir said about what is the youngest age. And I've been asking Nirmal, can you take these patients up, 20s, 18, 20, 22, lots and lots of patients. And so what do you suggest for that?
Sir, we have done 19 years, we have done hip replacement, and up to 21, you saw we have done both knee and hip also, because they are all fused joints. So when the patient is suffering, actually in a 19-year-old boy, we can't tell him you remain in the bed till 45 or 50, then you get a replacement and get a good life. And their life is just beginning. This is the time they should be mobile, they should be reading, they should be active, earning, and plan for the future. We can't make them lie on the bed for 60 years and then after 60 you'll be young again and run around. So if there is an indication, no age is barred for any replacement. I have done 19-year-old boy who was almost bedridden. He is now engineer in a Bhushan. It is almost 10 years. And he is doing fine. Maybe he will need a revision in future, but that is the norm. At least he has a normal life now.
Okay,
Entirely agree with Nirmal sir that even at a young patient, that main productive period of life is lost. So one has to make them productive. At least they have to work and they have to produce. Even a 32 years old male ankylosing spondylitis, as you told, both hips ankylosed, both knees ankylosed, bedridden for 15 years. He showed me in Orissa. I called him to KM, and he was there in KM for 6 months in the ward. We did one joint gradually, all the 4 joints, and they require a long period of rehabilitation because the muscles are so weak. They cannot stand and walk. So they require long period. So rehabilitated, and the patient went back to Orissa. Now got married. At least now he has a shop and is working. So otherwise he's better. Nothing is done. Now he becomes dependent on the others.
So I agree that the concept that previously we used to send, they said, no, you're too young. That concept has changed.
Yeah.
I agree fully, and I've loaded my patients on Nirmal. And of course, had you been there, I would have loaded you with more patients. The other thing is biologicals have actually helped us a lot. Now, before patients go into that stage, we put them on anti-TNFs and other things, and they're dramatic results.
Yeah.
So I think the number of patients will be bedridden, will reduce drastically once we have more aggressive biological therapy.
perfect. Thank you so much. Thank you. I think we have really, this is an interesting topic. The discussion can continue for a long time, but we have some time constraint. I thank from the institutional part, as a head of the institution, I have been participating almost every day till now. This is the 9th, I suppose, in the series that we have. Looking forward to all of you who have participated to please join in CME if you have the time. And also I would extend warm invitation to please attend, because all our programs from 13th of September are going to be live streamed. So if you have time, please log in. We'll be circulating the link in due course of time. I welcome you. I invite you to the Platinum Jubilee and SCBN Global Conclave. Please come and join us. With this pivot, I thanks everybody and hand over to our moderator, Professor Mahapatra.
Well, thank you, sir. It has been a very nice discussion. As we know, osteoarthritis is a universal disease and it has very less cure. We will be hardly be able to cure it, but we can offer some good solutions. And as you know, joint replacement is one of the most successful operations. I thank you all for being part of this discussion and hope whatever we discussed will improve your knowledge and understanding on these subjects, and maybe some of your patients will also benefit from these things. I thank our Dean and Chairman, our speakers, Dr. Subranchu Mahanti and Dr. Vishwajit, and all the faculties and friends and webinar attendees from our department, on behalf of our department. Thank you all.
Thank you.
Sir.
Thank you. Thank you, sir.
Thank you.